All, this is Dr. Mobeen Sayed from Drbeen.com. Welcome to one more show. This is our third talk for today, and I am actually fascinated and by the discussion we had this morning. So we're going to talk a little bit about the long haul. I don't want to spill too much of the beans because FLCCC is working on putting that algo together. However, I think there is some interesting topics that we should all know as well. With this, one more exciting news is that we will come live this Sunday as well at 11 a.m. Pacific time. This Sunday, that is day after tomorrow, Dr. Heather, so some folks, some fans on Twitter, fans or some Twitter, not Twitter, Redditors, they had asked me that if I could interview Dr. Sayed Heather. So I'm going to have requested Heather to join us. He said he can come in on this Sunday. And by the way, I called him Heather because Heather is actually his first name. Sayed is his last name, just like mine. Mobeen is my first name, but our names get flipped around. So he said that he'll be here on this Sunday. And so Sunday at 11 a.m. Pacific time, we'll have Dr. Sayed Heather. I believe Monday we have Dr. Jalali, and I believe 4th we have Dr. Pierre Corey, and then 10th we have Dr. Antonatos. And I'm going to request Dr. Hector Carvalho, Dr. Tina Pierce as well to join us as well in the coming days. So we have a lot of experts that would be joining us. So please remember this Sunday, Dr. Heather will be with us. So now let me just discuss a few things about the long COVID, which which I think I'm pretty proud that it was interesting that these discussions we have had before with the cool beans. So I want to connect some of it is actually very much in sync with what we have discussed yesterday. I guess the only correction in my discussion with you will be that, remember in the discussion we said that there may be virus persisting somewhere. So Dr. Merrick said that he is sure, and he has studies, and I'm going to go over those studies, which show that there is no virus found after a specific number of days. And he has maintained that from a very long time. And he said that, so there is no question of virus persisting. However, there is a possibility, there is a study, and he sent me that study. I'm going to read that over this weekend and then discuss it with you the next week. But the gist of the study is this, that there is this SARS-CoV-2, correct? So we know there is SARS-CoV-2. And the SARS-CoV-2 is kind of, it has a messenger RNA. It has not messenger RNA. It has RNA in it, which is messenger RNA for our cell. It has M proteins. It has N proteins. It has spike proteins. It has many other structural proteins. There is a study that says that after the infection is over, it is possible that in some people, an empty virus without the RNA, but the virus structure, the particle and spike proteins attached to it, may be roaming around in the cells, embedded in the cells. That is an interesting one, and I have to go over that study. If that is correct, then the thing that I have been saying that there may be viral persistence would have then be this, let's call it zombie virus, because it doesn't have RNA in it. That means it cannot replicate, it cannot divide, it cannot increase. It's just sitting in some macrophages or monocytes or some other cells and is just present. And that presence of this one, when it is broken down in the cells and the spike proteins are presented on the surface, then it would continue to create a immune response that is like the COVID response, but COVID itself is not there. This would also mean, according to Dr. Merrick, so these are credits to Dr. Merrick, it's not my discussion. This would also mean that if they end up, the patient, long COVID patient, ends up getting an RT-PCR test done, they may actually pick up some of these spike proteins and come back and say, hey, we feel this is positive. Although if the RT-PCR is looking at the genome, the RNA, then the RNA pieces may be just some pieces here and there. They may also make it positive, otherwise it would be negative. So this means what? This means that now for long COVID, the possibilities are, oh, and let me back up. One more thing, really important thing. All the doctors there, pulmonologists, they kept saying something which is very interesting for me, and I've been saying it from the very early time. And today I heard my own statement repeated in that discussion, and that was, remember I have been saying early aggressive treatment. So that statement was being used that, hey, we are seeing the lack of early aggressive treatment. And so some pulmonologists who were there, Fred, he was saying that, hey, when I see patients, I understand that there is a vastly underwhelming management at the beginning of COVID. So that was very interesting for me as well, because we have been asking for early and aggressive treatment. There was one more very interesting point, and I thought that was such a, so you can see that I'm happy because many of the things that we discussed were there. One more thing that was interesting was that doctors were thinking ivermectin is effective in majority of the cases. In some cases when ivermectin does not work at all. In some other cases as well, ivermectin works, but if you stop it, the symptoms bounce back. And then there are a majority where ivermectin works. So the question was this: why will ivermectin work but not other anti-inflammatory? Isn't that, if we say for a second that the role of ivermectin in long COVID is anti-inflammatory, and just to bring us on the same page, we know that ivermectin's roles, number one, blocking with the spike protein, correct? And the ACE. So that is one. Number two, we know that RDRP disruption. We also know the 3-chymotrypsin-like protease disruption. We also know that it prevents the viral cargo from going to the nucleus. So interferon production disruption is prevented by ivermectin. So ivermectin helps continue the interferon production. And then we also know that ivermectin works with the, nuclear factor KB, correct? This part, the last one that I'm doing, this is the anti-inflammatory part. The question is, why only the ivermectin as an anti-inflammatory and not other anti-inflammatory? So the answer is that possibly because there is other things that are going on here. So the answer for that was Dr. Marix. He said, well, that zombie virion that is running around in monocytes or macrophages, maybe it is that virion with its spike protein. And that spike protein is blocked by ivermectin. So it's not just the anti-inflammatory behavior. Now it is me completing the thought here. It's not just the anti-inflammatory behavior, it is anti-inflammatory behavior plus spike protein blocking behavior combined that provides that kind of an effect. And now if we say, all right, when we take a person off of ivermectin and they have the symptoms come back, that means these virions are still sitting somewhere. And this may be the reason that some folks who take a vaccine, they feel better after that. Not everyone does, but some. Because maybe the vaccine causes the immune system to be triggered, and that immune system then causes this virion to be cleared out. Now, stay with me. That is the ivermectin's role. Then if we think about steroids, In some cases, steroids work very well. I know that my patients responded very well to steroids. And the important thing to note here is this: early treatment, early management, steroids are actually important. During the COVID, anyways, steroids are important. Then, near the end of COVID, steroids are also important with ivermectin as a prophylaxis from long COVID. And what is the benefit of that? Look, if the immune system has developed abnormal cells that have certain genes opened up, and these immune cells are now making copies, and the new cells also have those genes opened up, and they're all making cytokines, then give them a rest, stop them, bounce the immune system, give steroids. At the same time, whatever is bothering the cells, maybe the viral debris, the virus, the virion, give ivermectin. So near the end, if you suspect that the patient is going to have become long hauler, and we'll discuss next week those markers for the long hauler in the active disease, if you suspect it, then manage them with steroids and ivermectin. That means if you cannot suspect it, you don't have labs, then give steroid and ivermectin at the tail end anyways. Doctors are giving it in the beginning. I'm afraid of saying steroid in the beginning, so I'm not using that word here, but ivermectin in the beginning and possibly even steroids in the beginning actually protect the patient from becoming a long hauler. So the role of steroid is now to reset the immune system, to give it a break, so that the original stem cells can start producing the more healthy immune system cells. Now, can that mean that we might not actually end up with a normal immune system? Yes, if the stem cell has become abnormal, then bouncing that stem cell back towards health may not be possible if there are no other healthy copies. But if there are healthy copies, then it is possible that stem cells would proliferate back towards healthy ones. So giving steroids is very important. Giving ivermectin is very important. Now, the third thing, some people do not respond to these things because their MCAS has occurred, macrophage activation has occurred. Why has that occurred? Because of this phenomena we saw here, this one. Because they responded to COVID, they responded with antibodies. Those antibodies went and primed their mast cells. It doesn't happen in everyone. Those mast cells have now become sensitive and they are responding. Plus, if there are abnormal immune system cells that are continuously making cytokines, those cytokines are going to bother the whole immune system, including the mast cells. So then that means antihistamines will be another area to make sure that you try. And the final part, which we discussed yesterday as well, is the brain fog and related issues. And for that, some people who do not have the stage of MCAS or mast cell activation, they would respond better to fluvoxamine. And those who are not responding to fluvoxamine would respond better to antihistamines. One thing that I don't think is going to be picked up in the bigger protocols is the importance of natural killer cells activations and the relaxation and exercises. And similarly, another thing that I think will not be there yet is the supplements. So we may have to put up our own page with the protocol as well to make sure that the vitamin Ds and those things are present. NAC is present. CoQ10 is present. Then we talk about the relaxation, yoga, or whatever makes you happy. Maybe watching a movie makes you happy, then do that instead of yoga. And then this. So wrapping up this discussion, and then we do chit chat. What is that discussion? Discussion is possibility for COVID. Number one, virions running around. So you can ask this question that, hey, why would a virion, let's say a virion is present here. It's a little particle without RNA. So it does not know how to duplicate. Why would this just stay on? One reason is that it is not broken down in time. So it is going to stay on till the cells can break it down. So the load of these virions or zombie viruses was too much and body would slowly take them out. So that means weeks and months later, person would become okay. So that's one possibility. Second possibility is that when this cell replicates, is it a possibility that these particles are replicating with the cell? So one possibility is the virion. And if that is a possibility, then both steroid and ivermectin will help. Second possibility is the, what is that? Macrophage activation syndrome, or abnormal immune cells. Abnormal immune cells. So here, let's say the macrophages are just continuing to make the cytokines. So in such cases, what do? Steroids. Bounce them. Third, MCAS. What do? So you try this plus antihistamines. And of course, then ivermectin cannot cross the blood-brain barrier, so use fluvoxamine. And if fluvoxamine increases the symptom, then antihistamines. That is the algorithm. So I'm pretty excited that we have a direction. I love Dr. Paul Marik and the way he thinks. He is so much thinking in the right direction, and not just sitting and thinking. He's reading studies, papers. He has read more papers than I have. I thought that I was one of the ones who had read a lot of papers and I have pulled together a lot of research, but he was talking about researches that I had not heard about. So he said, all right, I'll send you those papers. So that was fun. Dr. Marik was awesome. Dr. Joe, and because he's working with Dr. Bruce Patterson, and they have this clinic or a program for long haulers. So they, of course, are very much up with it. So we had lots of good discussion there as well. Dr. Corey was talking about his experience too. So I think it was a pretty neat discussion, and I feel there is going to be a positive outcome from it. Okay, so now let's start question answers. So let's start with Faizan. Question: is clotting can only occur in AstraZeneca? The way which you taught us by PL4, can some pathway occur in different vaccines, and we can have to avoid heparin in them as well? So Faizan, I have said this many times. It seems like adenovirus-based platforms, those vaccines that are based on adenovirus, they're known to have caused this issue. So Johnson & Johnson, AstraZeneca, Sputnik, and I believe there are some Chinese vaccines as well that have adenovirus. So Colin Hamill, what would be the best antihistamine? Very important question and very interesting answer. The answer would be antihistamines they vary by person, meaning you have to try which antihistamine works for you. So for example, anybody here, I would ask them to use Allegra and then start from there and see if they have to switch them. Also, the mast cell stabilizers are also important as well. So just sit down with your doctor and talk about stabilizers and antihistamines, and you may have to switch them. So I'm pretty excited that there is actually a pathway. The pathway or the algo is actually something like this. Patient arrives and they have long haul symptoms. Figure out if they have CNS symptoms or not, or the nervous system, because if that is the case, then you may have to start with fluvoxamine. If not, so let's say brain fog, concentration issues are not present, then you start with ivermectin, you start with steroids. You may start with antihistamine. So this is the main course. And then you start taking these out one by one and see what happens. And based on whichever you take out and the symptoms come back again, that means we need to focus on that area. So simple answer, but a lot of pathology and lot of thinking has to be done underneath. Okay, so let's keep going. Zan says, I wanted to ask about what benefits after losing the smell and taste sense, please. What benefits? I lost them so much, taste so low. I don't understand the question. What benefits after losing the smell? I didn't understand your question, Zan. Can you please elaborate? So Jody says, I use both Allegra and Benadryl. MJ says, after vaccination, for how long the antibodies test will show the presence on antibodies on the body. So it really depends upon everybody's immune system being different. The first dose should start triggering the adaptive arm somewhere from 5 days to 17 days. Mean is 9 days. And I'm saying that from clotting as well, because clotting follows the same structure. And then second dose should boost it. That means after the second dose, within 24 to 48 hours, immune antibody levels should start going up. And when they say that, hey, 7 days after the second dose or 14 days after the second dose, what they're meaning is that by that time they feel that optimal antibody titers have been achieved. Zia says, Dr. Corey was asked in his video on 428 about the vaccine shedding COVID. He was very strange in his answer and said at this time he didn't want to comment on it, but he is getting reports. So some folks have tweeted to me as well that vaccines cause shedding of the spike proteins. It's just not possible. And let's look at the mechanism. And they then tweeted to me the report. So there is a report somewhere on the FDA site, or maybe Verse or someplace, where they said, or maybe in a briefing document, where now I don't know if it is a doctor document or it is correct, that in there they had said that some person reported that when I stood next to a person who was vaccinated, I had, I don't know what, abortion or something. And the thing is this, if a person reported, that is not science. One has to actually figure it out. People say all kind of things. That's why we have the various terms. But here is the deal. Let's say this is a person who is given a vaccine, and they're given the vaccine in their deltoid here. This is why I made their arm a little bit like this. So here is the vaccine given. What we are saying is that after the vaccine, somehow the person's breathing is bringing out spikes, which when entering in another person cause some pathology in them. That is what we are saying. So now think about it. Number one, it is impossible for the spike proteins to end up in the breathing. And the reason, what is the reason for that? We have done this discussion, I think, now a lot of time. Here is a deltoid muscle. We have the vaccine over here. Vaccine will be picked up by the muscle cell, or by the macrophages, or the dendritic cells, or the fibroblasts, or many other cells sitting in this area. They're going to eat it up. It is 5 milliliter of vaccine with very tiny amount of the messenger RNA in it. They're going to eat it up. After they eat up that messenger RNA, then they are going to present the pieces of it. Remember, we have done this discussion. Messenger RNA is picked up. It is fed into the ribosome. They make the spike proteins. This is all happening within the cell. These spike proteins are then endosomes come in and they shred them into pieces. And those pieces are loaded on MHC1 and 2, 1 and or 2. And then they are presented on the surface of the cell, those pieces of the broken pieces of the glass of the spike protein. Then they are going to work with the immune system. Where is a live spike protein present in this whole process? Number one. Number two, let's say, fine, there are some cells that got broken down as part of the inflammation over here, and that breakdown caused the spike proteins, some of the spike proteins, to come out. Now what we want these spike proteins to do is to get, number one, absorbed in the blood vessel from or enter the blood. Then from the blood, they enter the throat area. Then from there, they come out in the mucus of the throat and just sit around so that they can be shed out. And then they have to be in ample quantity to be able to go to another person, and then somehow the spikes have to have some mechanism to cause abortions or some fertility issues. So that is just so impossible a mechanism. Meaning, so fine, we kind of hassle here and try to say this would happen while this is impossible. Why is it impossible, if you ask me? So let's say this cell is broken down and the spikes have come out. Those spikes will be picked up by other macrophages. This broken cell would be picked up by other macrophages. When a macrophage sees another cell dead, it eats that up. A macrophages can eat up to 100 to 160 cells before it itself dies, and then it is also eaten up by macrophages. So all of this debris is picked up by the dump truck or the trash trucks, and that is digested. So there is no concept actually of the spike proteins going out in the blood, then reaching the throat, then getting shed out. Okay, fine. We all did all of that. Now they are shed out for some reason. They are here. How would they cause abortion? So then we have to figure out another mechanism. So this would not happen. So then let's see. Loni says, great discussion. What happens in those who are immune suppressed through autoimmune medicine and organ transplant or rheumatoid disease? Please comment. So that is an area which is sensitive. So look, if we have gotten a person's immune system suppressed, so that means we don't have a robust system. We do not have robust innate arm. We do not have robust adaptive arm. So when you give them a vaccine or the infection, they are not going to be able to respond very well. Still, if you give them the vaccine, they would at least start preparing. That preparation would depend upon how much immunosuppressed they are. Denise says, FYI, Dr. Bean, my ID doc who had previous mast cell activation syndrome patients went ahead to get vaccine without her knowledge and are all knocked back down with MCAS again, like active infection. Wow. Sue says, can you talk about how the virus sheds? Yes. So, so let's say, let's look at the whole mechanism. Or let's start from the shedding. So let's say this is a person's mouth. I'm just going to make this little place. And in this mouth, of course, there is tongue. So now I'm going to make things. These are teeth. These are teeth. This is a tongue. And then in here, there is tissue, right? There are cells everywhere. And those cells, outside the cells, there is mucus, there is water everywhere, or spit, or whatever you want to call it. We call it mucus, right? So the mouth has mucus. Now what happens is, when the virus, if I take a cell from here and make that cell over here, so this is a cell now, so one tiny piece over here. When the virus lands on in our mouth or nose or eyes, what it does is it connects with the ACE2, and then ACE2 receptor allows the virus to fuse. There is TMPRSS2 and ACE2. So there's a process. The end result of that process is that the virus can fuse, the membrane can fuse with our cell's membrane, and RNA enters the cell. Then inside there, the virus makes more viruses, and then slowly the mouth becomes full of viruses, the throat becomes full of viruses, nose becomes full of viruses, and now they're all sitting in the mucous membrane. This is assuming the person is not vaccinated or was not infected previously, so they are kind of virgin about this virus and they cannot respond to it. And their response is going to come in a few weeks or days. So during this time, the virus is here, and that is why they would develop the symptoms as well. They would start coughing, they would start sneezing, they would start having sore throat, they would start developing fever, which means there is a tons of virus that is present. Now, whenever they would cough or sneeze or laugh loudly or sing or talk, those viruses are going to come out on droplets. So on the droplets that are coming out, the virus is sitting in there, and from there it would enter the other person's mouth or nose or eyes, and then from there it would do the same thing as it did before. So that is a basic process. Fun says, if someone is super horrified about the vax and took it anyway, is it right that their chance of having several side effects will increase? No. The only thing that is going to be a problem is that when you are stressed out, your NK cells are less. So your immune system may respond less with NK cell. Now, for vaccine, NK cell have no role. So no issues. I have my next date coming up. So today is 30th, right? So I have my next second dose on 5th. So I'm concerned that I don't know what would happen. Would I develop 2 days fever, myalgia and all that? I have no idea what symptoms will I develop, but I'm going to go and get it because it is important. Abdullah Musa says, why isn't one shot of vaccine? I think I answered this question before as well. We do not have data for the 1 shot versus 2 shots. The trial data that we have shows the vaccines result with 2 shots. UK has done an experiment to increase the window of time between the 2 shots. And they said that first shot towards the second shot, even after 3 months, the antibodies continue to increase. So first shot's effect continues to improve. And I think it goes about 80% or so. And then the second shot further boosts it. So why is it not enough? That is because the first shot's quantity is low. Now, would it continue to improve after some time? Yes. Can it continue to improve after 3 months or then would decline? I don't know because we don't have data. Exana says, the heart inflammation from Pfizer, does it occur immediately upon injecting or can it also occur later on? In other words, if I had the vaccine for 4 weeks and didn't happen, am I good? So yes, out of the 62 people who had the heart inflammation, I believe, or 56, I believe 52 of them had it after the second dose, and the remaining had it after the first dose. So the prevalence is more after the second dose. Doug says, natural killer cells target cells with decreased MIC1 expression. What else causes them to target cells? So natural killer cell, that is just one. So let me, this is a good question. So if you have been with me from the beginning, or if you watch my videos about immunology, I always call the natural killer cells, I don't know, I give them an eye patch and I give them a hand like this. So to me, they look like perverts. Why are they perverts? Because their role is to touch every cell they pass near. There are some videos on YouTube for natural killer cells and or the macrophages as well. And if you see them under the microscope, they are just going around and they're touching every cell. They're bumping into every cell. What they do is that when they are passing through near a cell, they would test the cell for the normal expression density. So it's not just the MIC1. They can see the density of various cluster of designations. Cluster of designations are just simple marker proteins or proteins just like we have here. So why do we have here? We don't have the answer for that. But similarly, cells have certain markers, proteins on them. And natural killer cells can actually see the density of the protein. And if the density is low, that means to natural killer cell, that means, so first they'll become a little thoughtful about it, and they would think that either there is an infection inside, and why would infection reduce the density of hair or these clusters of proteins? Because infection, for example, virus, will take over the cell machinery and make its own viruses. So the cell cannot make its proteins. So this is like some thief come into your home or somebody's home and start cooking using the products, but cook their own food. and not for you. So now you can't have food, but they are having food. So virus is making their own product, and the cell's product is not there. So that reduces the intensity. This can also happen with cancers as well. So natural killer cells function is also to detect cancer cells and kill them as well. And they kill thousands of cancer cells on daily basis. We all develop them all the time, especially with the light. And they just come in and they kill them. So this is what they do. So it's not just MSC1. They can find other cluster of designations too. So Westfield says, love that drawing. Thank you very much. They just they touch everyone. I can hear small cells telling the natural killer cells that, dude, don't touch me or I'll report you. This is what happens with the natural killer cells. V House says, doesn't the polio vaccine shed and cause cases of polio? Vaccine causing, meaning somehow the vaccine itself. So the type of the vaccine is different for polio. Now, I don't know if it should shed and cause polio, but the type is different. Loretta says, the speed of this chat is giving me vertigo. Well, the questions are nice here. Asadullah says, what are the relative and absolute contraindications of vaccine? I don't think there is any absolute contraindication. The contraindications mostly here in the US that we talk about is if somebody has severe allergies in the past, then they cannot take those vaccines which have polyethylene glycols, for example, Moderna or Pfizer. For adenovirus-based vaccine, I would say that somebody who had HIT in the past, heparin-induced thrombocytopenia, they should not take an adenovirus vaccine. They should take messenger RNA vaccines or inactivated virus vaccines. Other than this, in Netherlands, we saw that there were 23 deaths. And what happened there was that the people who died, they were too old and they were fragile, and they were not able to take the side effects, especially the diarrhea, nausea, vomiting. So imagine if you're a doctor, imagine you have a patient who has very less blood volume or is dehydrated, or his cardiovascular system is already not working correctly. If you put more load on it by dehydrating those patients, by causing diarrhea, now the heart has to pump more to keep the blood pressure up, and that heart may not be able to do it, and the patient might die. So these are the kind of reasons for contraindication. Otherwise, nothing. France is laughing at, dude, don't touch me. I can actually hear these cells saying that, hey, we're going to start a Me Too movement against natural killer cells. Zan says, I wanted to know more, please. What to do after I lost so much of my taste and smell? It recovers. It comes back so after some time. So take some anti-inflammatory and it would return. Chuck Becker says they get slapped in the eyes. Is he doing that? Yes. They don't have eyes. Yes, I loved it, Loretta. Westfield says, thank you, Dr. Bean. Really appreciate it. Very welcome. And thank you for the super chat. Learner Zero says, when someone develops the side effects of the vaccine earlier than someone else, when someone develops the side effects of the vaccine earlier than someone else, what's the interpretation for this? When someone develops the side effects of the vaccine. Oh, got it. So if two people got vaccines, one got the side effect today and the other one got it tomorrow. So there are two ways to get the vaccine side effects. One is the innate arm immediately responding and creating local inflammation and then maybe systemic inflammation within a day or two. That is innate arm immediately responding, and that can happen in some people and not in others. Does not matter. If innate arm is still working, we get lots of infections all the time and our system is working. It doesn't have to give us fever every time. On the other hand, there can be another set of side effects that would appear from 5th day onward because of the adaptive arm becoming activated, antibodies becoming produced, and inflammation because of the antibodies being produced. So these are the immediate reaction and then a few days later. For example, thrombosis occurs 5 days onwards. Texas Max says downtrodden cells, those NK types, yeah, they're really bad. And not only this, that they go and touch every cell, they kill them if they don't like them. So they're kind of the not so good cells. They're actually good cells. They're helping us. Art Ninjiok says, if vitamin B1 help guide the immune system to go T helper 1 pathway, does it cause MCAS that can be treated with antihistamines? Can help. So first thing, I do not know if B1 can actually help guide immune system to T helper 1. That is my ignorance. Do it cause MCAS that can be treated with antihistamines? That I don't understand. Does it cause MCAS would happen when T helper 2 pathway is taken? And please remember, I don't want to be known that Mubin said MCAS can only occur with the B cell activation and immune antibody production. MCAS can occur because of many reasons. Mast cells are just very, very delicate. They're very moody, and they can just degranulate for no good reason. And so it's not necessary. But if we're going to go MCAS route, that would be T helper 2 pathway. So Oksana says, thank you, but what I mean is after taking the second jab, does the risk of heart inflammation persist forever, or is it just a few days? Few days. So the antibodies are produced, and if these antibodies are going to attack the heart, it would just be for a few days, and then the antibodies would decline. Antoinette X says, Dr. Tenpenny, Dell, Big Tree, frontline doctors say the vaccinated person sheds or transfers variant viruses to everyone. Other sources support this also. Shedding a virus is not a miracle. It happens. That is why we catch viruses. And transferring the variants is also not a miracle. That is fine. It happens. If I have a variant, I'm going to shed the variant. So what is the science here? Hubert says, what happens after a vaccine gets injected into a muscle? Where does it go from there? So very quickly, I just drew that a few seconds ago, but let's say we go back to that diagram. So actually, let's make a new diagram. So here is the, let's say, deltoid muscle. I'm going to make it a little bigger to kind of show inside of it. So deltoid muscle itself has some muscle fibers, correct? So let's say this is a muscle fiber, this is another muscle fiber, and this is another muscle fiber. Of course, it has millions of muscle fibers. I'm just taking some. In addition to that, there are macrophages sitting here. They are sitting everywhere. There are dendritic cells that are sitting here. They are sitting everywhere as well. There are fibroblasts that are sitting here. And there are many other kind of cells that are here. When the vaccine is given, so let's say this is a few chunks of vaccine, lipid particles, or adenoviruses. They both have a different destination or different way of moving forward. I've done those in lots of detail before. But what happens is, let's just use messenger RNA. This particle is going to be picked up. First of all, it is not going to be left here. Our immune system, our macrophages, neutrophils, dendritic cells are not going to leave it here. They're all going to gang on it, the vaccine, and say, my God, what is it? And they're going to start eating it up. They're going to start phagocytosing it, breaking it down, and seeing what that thing is. This is what happens with everything that is not our tissue. Anything. You can try it. Do an organ transplant and you see how our body reacts. Give somebody blood transfusion and you see how our body reacts. Our body does not allow anything to enter its boundaries inside of it. So now here is these particles. These particles are designed in a way that they can cross the membrane and enter the cell, so that they can get into the cell and become part of the vaccine process. So once they are inside the cell, they could be inside a normal cell, for example, muscle cell or a fibroblast, or they could be in the professional cells, for example, macrophages and dendritic cells. So then once they are taken up in there, they would help make the spike proteins, and the inflammatory process would start. In that inflammatory process, there would be some destruction done here as well. That is why you will feel pain. And then there would be some of the dead tissue here as well that would be created microscopically, and that tissue would also then be taken up by the other macrophages and eaten up and removed. So that is what happens to the vaccine. Alex Hunter says, did they do any study categorizing the cell types these jab particles enter, or are we just dumping everything everywhere, hoping for the best? So, Alex, we
Sorry, I don't know that.
Stop, Alexa. I'm talking with Alex. So, here's the deal. The good question. So, inside the deltoid, we are putting the vaccine in there, as you said, dumping it there. So, we are dumping it in the deltoid tissue. Good news is that within the deltoid tissue, whatever cells type, and we doctors study this in detail, that what is the histology. If I show you just for kicks, that what kind of details we study these things in. So let's say histology of a muscle. And if you go to the images, I still remember these these things. So they would show up. These would be the slides. So microscopically, here is how a muscle is, and you've got to recognize what are various cell types in there and what are the tissue types in here. And they can ask you, where is this cell or where is that cell? So that is how we study. I don't want to continue showing it because of the copyright issues, but so we leave it in there. There are cells, muscle cells, macrophages, dendritic cells, fibroblasts, and other cells as well, connective tissue parent cells too, and they would do their function of eating up the vaccine. Good question, Alex. Doug says histology wonderful. Yes, I used to become so annoyed with histology. You have to remember what is where is what. Richard John says, question, are there any studies showing that ivermectin doesn't work? If so, how many? Just that one study in JAMA, which study itself was rigged, but that study shows it doesn't work. So that is one. I am sure that there are the opponents of ivermectin working on more studies which would show it doesn't work. There was a Skyfrog says, so if muscles are made of muscle fibers, if I eat steak, am I eating fiber? Yes. So it is not the vegetable fiber. It is protein. So muscle is protein. So the fibers, we call these fibers the muscle cells are elongated tube-like things, and under the histological slides, they look like fibers. So that's why we call them fibers. But good question. I think you were being facetious. Peking says, Doctor, if the vaccine can still be effective to the infectious variants, then why did South Africa refuse millions of AstraZeneca vaccines? No idea. Maybe AstraZeneca's vaccine efficacy is not that great for South Africa. Pfizer showed good efficacy. So I do not know. I have to read up to see what was their reason. But vaccines can be, are efficacious. Zen says, I love histology and cytology at university. Awesome. I love drawing cells. I don't love remembering cells, although now I remember some of them. Algebra Bean says, if vaccines or recovery from COVID create immunity and memory, if vaccines and recovery create immunity and memory T cells, why are boosters being suggested 12 to 18 months after disease or vaccination? So very good question, Algebra Bean. So let me give you an answer in their favor and an answer contradicting what they're saying. In their favor, there could be, number one, creating expectation. So people don't create noise when they come back after a year and say you need a booster. So one is managing expectation. Second possibility is that they're thinking, all right, we have variants and these have reduced our efficacy. Maybe if people are not getting vaccinated, or if there are variants that just continue to emerge, then a year later there would be enough difference produced in the spikes that our current vaccines are not going to be very efficacious, or the level would drop below 50, for example, and we would have to give a booster. So that is pro their statement. The contra comment could be that so far, after a year and some months, there are no variants that can escape the vaccine so far. And if a variant, I've done this discussion many times, if a variant changes so drastically that the antibodies, existing antibodies cannot connect with it, then how are we saying that the variant itself can continue to function, because now it has a totally mangled spike protein? How would that spike protein work with ACE2 receptors anymore? So it's not just that the variant is disabling the antibodies and their connection, variant is disabling itself as well. And then the third contrapoint is that usually when the variants emerge and they become more contagious, they become less lethal. So in this process, ideally, the SARS-CoV-2 has to become adapted to humans and stop bothering us and live like other coronaviruses in our throat. So as the time passes, it should become more mild for us instead of more dangerous for us. So there is a question from Bonnie. Could you please check out Dr. Surya Kant from India? He had a white paper on the WHO site and he's a pro ivermectin. How did he end up with the white paper on WHO if he's pro ivermectin? He seems to know a lot about what is going on in India. Absolutely, I would love to. Is there anyone who can connect me with him? I would love to have a talk with him. So it seems like a good question. Is there any big difference between coronaviruses in their respective receptor binding domains? If the answer is no, then could the vaccine against canine coronavirus helps humans to be more protected against SARS? That's what we saw with the fusion protein. So they are saying that the RBD, receptor binding domain, may still be mutating, but fusion protein across all species of coronaviruses is more than 90% similar. So that is the vaccine they're making. So maybe right now you just thought of the super vaccine idea, which was pitched a few days ago. So you are a good scientist as well. Okay, so continuing on, more questions. Fun says, can young persons get blood clots after 1 month of recovering from moderate COVID infection? If you don't have any lingering symptoms, then no. Why would you develop blood clots now? No. Okay, more questions. Nancy Park says, so forget about testing for IgG and latent virus in the stools. Is that a question, Nancy? So question related to? Art Ninjiok says, here in Canada, we have presumptive cases. Would this mean presumptive cases are positive tests seen with a lower cycle threshold? Possible, yes. A lower cycle threshold becoming positive can be a non-symptomatic issue. So possible. Jody says, in 2003, the National Organization of Rare Disorders gave a protocol for myocardium after vaccination. It's no exercise, 3 to 6 months, low carb and sugar diet, only 1 alcohol beverage allowed per day. Thoughts? So really what they're trying to do is, the problem with the heart inflammation is that heart is always working. So if there is something, I'm sure that there are other things in our body as well, but one big mechanical thing is heart, which never sleeps or never rests. It does rest and then pumps and rests and pumps and rests, and that's about it. Otherwise we are sleeping, we're doing things, and it is working. So it is always mechanically in a sensitive place. So if it is inflamed and the person kind of exercises it more, then that can cause rupture or cause tissue damage or cause peritoneal tamponade. There are many things that can happen, not peritoneal, pericarditis and tamponade and so on. So because of that, they're saying that, hey, keep the low carb so that you have less inflammation, do less exercise so you don't accidentally cause it to work so much, the heart, that it becomes damaged in that process. So interesting protocol. Arun says there is strong relation between megakaryocyte, thrombocytes, and COVID. Can you please make a COVID video on that? Sure. Megakaryocytes are the, it is so fun to see what they are. So just a very quick one. Inside the bone marrow, so let's say we make a vertebra. Let's say this is a vertebra. Right, so this is a vertebra. Inside the vertebra, we have bone marrow, correct? We have bone marrow here. Inside, if we look inside the bone marrow has many, many fibers, connective tissue fibers. This is, when I think of this is why I'm so visual. When I think of bone marrow, I think of like a jail. So there are lots of fibers in there. Inside those fibers are big cells and small cells. These cells are sitting in there and they are making other cells. So they are stem cells and they are helping make other blood cells. One such stem cell is called a megakaryocyte, mega. So it's a big cell. When the cell becomes formed, it becomes so big that it starts breaking off because of these fibers act like slices, like knives, and smaller pieces of it break off. Those smaller pieces are called platelets. So megakaryocytes are parents of platelet. The difference between them is that megakaryocytes are actual cell. They have a nucleus in them and they have a functioning structure. But when those platelets are pinched off of them, the platelets do not have nucleus in them. That means whatever enzymes we have given to platelets, they can only live with those enzymes and nothing else. And whatever time they can use them, that is how long they are functional. When they have used their pocket money, they're dead. So that is the relationship between these two. The thrombocyte is when these platelets aggregate and they become, actually, sorry, thrombocytes are actually platelets too. So cyte means cell. So there, I was going to talk about thrombus. A thrombus is really just the platelets sitting together. Thrombocytes are nothing but the platelets. Megakaryocytes are nothing but the platelet parents. Or this is a really good parent that they actually pinch off pieces of them and they become platelets. Okay, so that is done. So let's do a couple of more questions and then William Goff says, so thank you for the super chat. It appears as though the two biggest risks of the vaccines are blood clots and myocarditis. Should we all just prophylax with 81 milligram aspirin and Motrin daily for a few weeks? So I know that you yourself are a healthcare worker. So between you and me, I would say that it is the best thing to do. But I cannot advise that to the general population. So as an educational concept, yes, if everybody prophylaxed with the blood thinners, it can help. But also please remember that not everyone can take blood thinners because they may already have blood disorders, and that is where the issues can come. This is why it is important for listeners. Blood thinners cannot be taken, although aspirin 81 milligram or smaller dose is not, people take that on daily basis, but still talk with your doctor first. Blood thinning is not a harmless thing. One more question. So Zia says, so let's just have the statement and then we'll stop. My partner thinks I'm in a cult here every night. Sorry, honey, but I need to sign in now to Closet Dr. Bean and the Cool Beans. Addicted and most likely single. So yeah, sorry about that. So with this, let us stop for today. Thank you very much for your time and for being with me. Um, Tomorrow we'll have an off. Sunday, 11 a.m. Pacific time. We'll have Dr. Syed Heather with us. I'm going to tweet about him as well. So if you have any questions, we can have those questions. Please like, subscribe, and share. And if out of these three you want to do just one, then like. And then there are 3 links in the description as well to support this work. One is if you don't want to use PayPal, then you can use Buy Me a Coffee, or you can become a patron, or you can use PayPal to support this work. Thank you very much. Stay safe and happy and healthy. And I would see you on Sunday at 11 a.m. Pacific time. Bye-bye.